Fantastic, thanks, Medive. Hi, my name is Natasha. I'm the KPO lead, and I get the pleasure of hosting Report Out today. And it's the best of both worlds this week. I'm going to get to hear about the RPIW and the event that's going on around medication incidents. And I didn't manage to get to open lunch this week, so I've been chomping at the bit to hear about everything that's gone on. So brilliant, can't wait to hear about that. And then we'll hear from Jenny about her project that she's using for a LIM certification. So we'll do both back to back, and then we'll stop for questions and comments at the end of it. So I'll hand straight over to the big team in the room. Are you ready to go?
Yeah, we're ready to go. So hello everybody, my name is Catherine Essex-Jones. I'm an improvement specialist in the KPO team, and I've been workshop lead for this event this week. So we've been doing an RPIW with the MMPS and Leeds Children's Hospital, looking at the investigation process for medication incidents. So what happens when a medication incident occurs. Although we're looking at it generally, we use as a test site L31, L33, which is paediatric hematology and oncology, and L47, which is paediatric ICU. So the team really wanted to at the start of the week, and we were set the challenge as well by our sponsors to reduce the lead time, which Adatix is open for from 37 to 19 days. The team really wanted to reduce, there is a bit of a blame culture around medication incidents, so the team did really want to reduce that as well. And we really want to ensure that learning from incidents leads to tangible improvements in medicine safety. So that was the aim for the week. Next slide, please. Oh yeah, and this is just our project form, which outlines everything I've just said in terms of what the plan was for the week, and everybody that was involved in that. Next slide, please.
Hello, my name's Katie. I'm an improvement specialist in the KPO team, and I was team lead for this week's event. On the screen, you can see our target progress report, and that shows the baseline data from the beginning of the event, and then the targets that our sponsor set us. Next slide, please. This is our value stream map. We can see from here the steps in the process from the medicines incident occurring to the incident being closed, and in that there's the actions that follow the incidents too. So at each step you can see where there's value added and non-value added time spent in the process, which gave us our opportunities for improvement, which you can see at the top there in the clouds, colourful clouds. Next slide, please.
Hi, so my name's Charlotte Thorpe. I'm the ward manager for Ward L31, and in this project I've been a process owner. So the first PDSA that we've devised is the medication safety debrief. This is a Microsoft form with the intention of that being completed with members of the MDT, so a pharmacist, a nurse and a member of the medical team within 24 hours of the incident occurring. The aim for this form is to ensure that we can implement immediate actions to prevent further harm to any other patients. And it's also to share the learning with the whole of the MDT within the first 24 hours of it occurring. On average, this process, when tested on 31 MPICU, has taken around 12 minutes, and previously it's taken around 2 hours. The information that we've been able to gather and the changes that we've been able to make through this process have actually had significant value, and actually the information we've obtained through looking at it through different lenses has been really valuable and meant that the quality improvements that we've done have been much better than previously. It also, the form comes straight back through to the Datex handler, so that really aids them in being able to assign actions on the Datex in a timely manner, again to ensure that quality improvement projects can be carried out long term as well as within that sort of immediate 24 hours of the incident occurring. Already some of the positive feedback we've had from members of the MDT is a medic who was involved in the process said that he would review a prescription chart very differently following being part of the medication safety debrief, and he also said that he would never have previously had any insight or any awareness that this incident had ever occurred. A pharmacist thought it was a brilliant idea, and she was actually able to feed the information back through to her peers face to face in a really timely manner. And this has resulted in us being able to make an improvement already to what we've seen as a reoccurring theme that previously we've really struggled to actually do. So hopefully that will mean that we won't have any further incidents going forward. It's also resulted in some positive parental feedback. So today, within 24 hours of an incident occurring, I've been able to speak to a parent, and part of his day text was part of their sort of verbal complaint that they wanted to go through with myself. And actually, by me being able to feed back changes that we had made to prevent this from reoccurring with her child and also any other patients within our unit going forward, that direction of that conversation and complaint has already changed and actually has become more of a positive process for them. Next slide, please.
Hello, my name is Sarah Holmwood. I'm working with the Children's Quality team. I'm also a process owner throughout this investigation stuff. We used a PDSA approach in order to analyse the initial process of using the datix. And you can see on the slide at the bottom left, there was lots of pink post-it notes, which indicates the waste that was used throughout the whole process initially. By looking at that, most of it was communication in order to investigate the incident, and within the MDT. And then on your chart at the bottom right shows how the new process works, and that the majority of that waste has been eliminated because the MDT are already involved within the process from the start. The datix team also came and were involved this week too to ensure that we understood how the datix form can be used to its most beneficial, and we have been able to create a handy hints form that we are going to circulate for users so that will enable all of the appropriate information to be there for the investigation, which will also reduce some time in the process. We've found that from it taking 37 days, from start to finish, one this week has literally took 6 days to complete, so hopefully that will continue in the future. Next slide, please.
Hello, my name is Sue Parkinson. I'm the lead pharmacist for medicine safety, and I'm also a process owner for the event. We've had multiple discussions throughout the week on how information flows following an event across the trust. And what these conversations have highlighted is really how complicated that flow is. It's also complicated by the fact that some aspects of the flow of information is related to assurance, whereas others are related to learning and improvement. So one of the things we've learned is we really need to have a look at this to try and make this more straightforward. This is going to form part of our 30-day plan review, and the KPO team are going to support us with that. Once we've had a look at that, we're going to look at how we share learning identified back down to the staff actually delivering care to patients. That we're going to put as part of our 60-day work plan. Next slide, please.
Hi, my name is Danny, and I'm one of the lead professionals for safeguarding adults in the trust, and I am an away team member for the RPIW week this week. At the start of the week, we were shared the results from the staff questionnaire, and a resounding theme that came through for this work stream was the blame culture associated with the medication errors. And as mentioned previously, it became one of the challenges for this week from our sponsors. We discovered that currently within the nursing teams, the Just and Fair document was frequently used as a tool for any medication error reviews, and has in some part created a culture of blame, particularly at the administration end of medications. As you can see on the slide, feedback from staff surveyed felt the process was quite criminalised, excuse me, sorry, and that nobody sets out to intentionally make a medication error. So why were they being accused of this within the document? This week, we discussed the current Just and Fair document, and whilst it wasn't in our gift to totally remove this process immediately, an action was kindly taken by the nursing MMPS team to review the use of this document with a view to reducing the use of this document or changing the way we do this. Instead, to avoid a person blaming approach for medication errors, and similar to the hospital-acquired infection process, where no one individual is named or blamed for not washing their hands, for example, we have introduced a more systems-based approach to incident reviews, By looking at things like processes, environmental factors, technology, and organisational issues, we felt that this would help create a more psychologically safe culture. So now, as part of the clinical staff handovers and the new medication safety debrief, we are hoping to create a positive narrative to help staff lead DATIX reviews under the title of Shared Learning and encourage a supportive and beneficial MDT discussion. Within this, we've also added a positive feedback session to acknowledge those that have identified concerns and to encourage a safe, open and non-blame culture. Next slide, please.
Hello, my name's Andrew Fester. I'm a PICU consultant and I was an away team member for this project. There was, as part of this project, identified some areas which currently are beyond the scope of what we can change. And those are for now parked in what we call the car park. They include things like the financial approval for resources required to prevent errors, any kind of study leave requests for staff at the moment. The DATIX, as we've discussed, some of the DATIX questions are in fact mandated by NHS England and therefore beyond our powers to kind of shorten or truncate in any way. We also looked at the fact that there are multiple systems in use for prescribing, both digitally and also a combination of paper and digital prescriptions, which can sometimes make the information difficult to check. We also, as we've mentioned in previous slides, looked at the trust governance structure and how the flow of information both up the chain and cascading back down the chain could be improved. And the final thing we looked at as well was the time for doctors to be able to attend forums in order to help with improving quality in the future. Next slide, please.
So the newspaper is a summary of our action plan for the next 30 days. We've got weekly meetings set up to make sure that we're on track with these. Next slide, please.
So the PDSAs that the team have done this week show quite a significant difference between the percent load chart before and percent load chart afterwards, which shows where the burden of work lies with each operator. So you can see that's a lot more even and a lot of time taken out of the process, which for the clinical staff is time back to care. Next slide, please. On our target progress report, you can see lots of greens, which is really positive.
Sorry, I think we might have lost the sound from the team, or are they frozen? I think by the looks of
It looked like they're frozen, aren't they?
They might have frozen. Oh no. Well, as Kate was saying, there is a lot of green on that TPR. They've done a hell of a lot of work this week. Madupe, I'm wondering if you can just move us on to the next slide and we'll see if they come back. No.
I think the last bit was just just to say thank you to everybody that had been involved this week. Sorry, I'm at home, so I can just.
Oh, brilliant! Thank you for stepping in.
But yeah, just to thank everybody. It was a really valuable week to allow people sort of off the shop floor for a week, and there was lots of support from colleagues who obviously allowed us to do that. So thank you.
That's fabulous. Thank you so much for stepping in for the second bit there. Laura, do you just want to come in? Is there anything you'd like to add?
Oh, thank you. Just leaving us on tenterhooks. Sorry, Danny, are you able to say what we got down to? A little quick summary of those timings. Do you know?
Sorry, just in terms of, I think from the actual debrief, that was about 12 minutes. Which was much quicker, obviously, than the normal. I can't remember off the top of my head. I think it was something like 800 minutes was saved in the overall process. But apologies, I don't have that data in front of me.
No, I think if we go back a couple of slides from their TPR, it looks like they've gone down from their lead time. It was originally at 37 days, but I think they did mention that they managed to do it within 6 days. As a test of change.
Can you hear us now?
Oh, you're back. Yes.
We're back. Yeah, we've switched laptops.
Oh, fabulous.
Yeah, go on, sorry.
No, we were just trying to kind of ascertain where you'd finished for the week. So we're just looking at the difference between your baseline and then your final 6 days that you got there. Wondered whether there's anything else that you'd like to add?
Yeah, obviously the lead time is the big hitter, but to be honest, I think the most important change is what Charlotte discussed about. We managed to make real tangible improvements because of this huddle that they've introduced, which is really powerful. I just wanted to highlight how great the team have been this week. There's been some operational challenges, like improvement mindset. It's been challenged at times and people have challenged, but I think that's been really positive because that's really helped us get to something that's going to add value. And yeah, we've really valued the kind of frontline input of like all staff. We've had, nurses, doctors, pharmacists, loads of colleagues from across the organisation. And that's been really, really helpful, I think. If you do the next slide, I'll just say my thank yous and then I'll close off for questions if that's all right. Yeah, just thank you to our sponsors. So Laura Wokes and Marianne Taylor from MMPS and Bridget Sutton in the Children's Hospital, as well as Sarah Kehoe, who also sponsored the event from across the organisation. Tans came and did some human factors training with the team, which was really helpful in moving some of the thoughts on the first day. So thank you to her. Big thank you to the youth team because they let us have their room, the place to be for the week. And it's been a really great place to do improvement. So thank you for that. Datix team as well, Eve and Ash came. And I know Eve's left now, but they were fantastic in terms of giving us stuff about Datix and generally just, the home and away teams, the commitment to improvement under extreme operational pressure. Like, it was great. Thank you so much.
Thank you. And I can see that we've got a few hands up. If you want to keep them up, we'll come back to you. But I'm really conscious that we've got Jenny ready, waiting in the wings to feedback. Jenny, I'll hand over to you and then we'll come back to questions and comments at the end.
Thank you, Natasha. So hi everyone, my name is Jenny Roddy. I work as a consultant midwife, focusing on tackling health inequalities and public health within the maternity service. I'm here just to describe the project that's ongoing, really, that I've used as part of my LIM Intermediate project. It is a rather large project and I'm really going to struggle to do it in 5 minutes. But it is there's a bigger piece of work looking at improving data capture, education and prevention messaging. But I'm going to focus on increasing access to the National Diabetes Prevention Programme for people with a history of gestational diabetes in pregnancy. Next slide, please. So the problem that we had was that in Leeds we have rising rates of gestational diabetes, which is a temporary form of diabetes that just occurs in pregnancy. And we've seen a rapid rise. So last year, 12.7% of all of our births were complicated by gestational diabetes. And that's huge because back in 2011, it was only 3%. So it's risen, astronomically over the last decade, really. And it's problematic because it impacts on health inequalities, it impacts on our service delivery, and it impacts on healthcare sustainability. But it has lifelong and intergenerational impact on population health. So 50% of women who have GDM, so gestational diabetes in pregnancy, do go on to develop type 2 diabetes within 5 to 10 years after birth. So it has huge impact. So I created a smart aim for the project, which was to implement a secondary care referral process into the NHS Diabetes Prevention Programme for all people at LTHT diagnosed with gestational diabetes. And we wanted this to be measurable and time bound. So we wanted to achieve at least 50% of eligible women being referred within the first 12 months of the pilot. And it impacts on the 7 Cs for us, really, because a focus on ill health prevention would improve care. It impacts sustainability and it'll be financially rewarding as well for the trust and the wider system. Next slide, please. So this is just to show you, really, NDPP, or National Diabetes Prevention Programme, is a 9-month evidence-based behaviour change programme, and it's for people who are at risk of developing type 2 diabetes. And anybody that completes the programme actually does reduce their risk of developing type 2 by over 1/3. And it's free for people to attend. So this is why we really wanted to focus and harnessing on this. But when we looked at the data in primary care, we could see that actually less than 1% of the at-risk population, so those women that were coded as having a history of gestational diabetes, actually were referred into the programme in 2024, despite you know, despite a self-referral mechanism. So only 33 people across the whole of Leeds out of 4,951 eligible. Next slide, please. So what were the actions that we took? So we wanted to understand the problem more closely by looking at the data, and this involved needing to understand the primary care data too. And I really needed stakeholder buy-in, you know, to be able to do that. I knew I couldn't do it on my own with a small team of us here, you know, in maternity. So with a lot of persistence and hard work, we managed to form a working group that spanned public health, the ICB, primary care, and us in secondary care. And I used stakeholder analysis to help me identify and I prioritize the key influences at, you know, at an early stage. We used process flow mapping to find a way to integrate the referral and information giving process into existing antenatal care pathways. And we used different iterations of PDSA cycling to try and work out what was the best time to add in that referral into that existing pathway. Was it either at the time of GDM diagnosis or potentially towards the end of pregnancy? Time observation charts helped us to assess the impact on workflow of both options, and we went with at diagnosis in the end. Team engagement really was integral to all of this. We held regular stakeholder meetings. I presented alongside a public health improvement specialist at 3 primary care target events, you know, to build knowledge in this area and awareness. And we co-developed a standard operating procedure which assisted with promoting shared ownership of the change. Next slide, please. So how's it going so far? So we started in January, and I'm pleased to say that we've had 619 referrals since January just this year, which, you know, compared to 33 last year is huge. The engagement is the thing I'm really interested in. And what you find often with, you know, public health improvement programs is, you know, that the attrition rate is usually quite high. But we did find so far that we've had 47% of those referred that have attended the initial assessment. Of those, 10% of them have attended face-to-face programme and 74% of them have attended the digital programme. As we're only sort of November, I've not got much data yet on the completion of that programme because it's a 9-month programme, so it's a bit of a longer game is this one. Next slide, please. So what's gone well for us really is, you know, ongoing evaluation and improvement cycling. For me, really key multi-stakeholder engagement, particularly across the city, really. And what's come out of that is lots of shared learning and networking, and actually ultimately data collection improvements across the system, particularly within primary care, because we were looking more long term as well for the evaluation aspect of this project. Next slide, please. So what would I do differently next time? Well, we did already have service user insight that we had from working with service users around this topic area in deprived areas of Leeds previously, which we used to help give us insight and knowledge into this pathway. But actually, I'd probably have service user involvement from the offset if I was to do this again, to try and help us understand better when is best for them and when is, you know, to introduce a referral mechanism and how is and when is best for them for us to deliver that information. Some really key learning from that, you know, that's come across for me really is that, you know, data really does drive insight. Data is a huge part of my role already, but having access to accurate, timely data is really essential to allow us to identify gaps and track progress really, you know, and understand and monitor the impact of the intervention. Early stakeholder engagement is critical, and it really helps build trust, build buy-in, and enhances collaboration. You know, what I found actually was already people doing work on this in this area, and it saved duplication as well. An iterative approach works. You know, we know that QI is not linear, so testing small changes, evaluating the impact and allowing for adjustments can improve the effectiveness of the intervention that you're trying to do. And for me, equity matters. So I've built in a way to monitor demographic data as part of that engagement with the programme that we refer into. And that is going to help us and support us to address disparities and promote equitable access in the future. Some personal reflections is that QI requires patience, as the impact is often gradual. And I certainly have found that working within tackling health inequalities, it's a bit of a long game. And sometimes it takes a little while to see that impact. But actually seeing the data-driven changes translate into patient outcomes is rewarding. You know, I'm over the moon with the number of people so far that have, you know, engaged in the programme compared to last year. So the next steps for us is evaluating the impact of the change, and I'm going to begin to start a large evaluation in the early next year. And I'm going to be looking at, what is the impact on sustainability and longer term health outcomes. I think for longer term health outcomes, that may take a little bit more time. But essentially, what's the engagement and attrition rates for the NDPP programme once we've referred in? And are there any disparities in engagement in the programme from a health equity lens? So we've worked with the provider of the programme to really look at actually who is engaging, who's not engaging, and that's going to then allow us to target and focus that improvement further as we go along the project. And ultimately, what is the experience for families, and is there anything we need to learn from there to help improve that referral and information giving? And that's it from me. Thank you.
I'm like blown away by that. 33 is over 600. Jenny, that is amazing. But before I wrap it on and take all the time, I'm going to hand over to the people that have already been patiently waiting with their hands up. We'll go to Danielle first.
Oh, thank you. Hi, I'm Danielle Ling. I'm one of the paediatric oncologists. I just wanted to say a huge thank you to Katie and Catherine from the LIM team for this week. It's just been really great opportunity for us to meet colleagues from the MMPS team and beyond in LTHT, and I think we're really excited within the Children's Hospital to take this work forward with medication improvements, safety improvements. Personally, as a datix handler, it's been a real joy to see the immediate learning within the MDT. We've kind of tagged it onto our morning safety huddles, which have, so it's already a time when we're all coming together. And as a datix handler, it's been such a joy to be able to close and close off incidents quicker and assign actions, actually. So I think there's going to be some real impact on our patient care as a result. And we've also managed to convince the LIM team to help us with our chemotherapy pathway improvement work as well. So the improvement work continues, but thank you to the team in the room there. It's been really fun this week, and yeah, thank you for the other presentation too.
Oh, that's brilliant. That's amazing feedback. We'll go to Karam next.
Yeah, thank you again to the team. I'm a PICU consultant and the lead for quality and governance in Children's Hospital. So I didn't attend the workshop myself, but I can see how much hard work must have gone into it. So thank you again for everybody. I just have a few comments about the shared learning that was kind of briefly mentioned. It'll be actually quite useful to have somebody from medicines management or pharmacy to actually directly join the monthly QAG meetings, because that's where we tend to share most of our learning with clinicians, because I think we're currently missing that in terms of learning from incidents as a theme overall, because that will be helpful. The other thing I want to talk about was druggles. So some units in Children's Hospital use druggles, which have received really positive feedback from staff in terms of learning from incidents in more real-time kind of activity rather than reflecting on them later on. So I was just wondering if the team had any thoughts on it. And then the last bit was about the governance structure. So there was a car park theme about not having current governance structure for medical incidents. I think the main way we look at things is through data access and how they're reported and the quality of them being reported. We don't only look at the ones where there's significant harm, but actually if there's any theme upcoming. So again, I think what will be useful is to have shared learning from the medical team, medicines team on a regular basis, so we can look into the current structure and decide if things need to be changed. So that was all my comments, and I don't know if anyone got any feedback on it. Otherwise, I can catch up with the team afterwards.
I think Anna's going to come in on that.
Hi,
hi, Anna.
Hiya. I'll tell you all. We did discuss it quite a lot, actually, which is probably an oversight not including it in the slides, actually. So I've got a plan.
Fantastic, Anna. I didn't see you there, so we'll catch up. Thanks, everyone.
Oh yeah, sorry, yes.
Yeah, I'll take on an action to talk to the clinical pharmacy team leader about who's the best person to attend your QAG.
Wow,
Thank you. That would be amazing.
Okay, Leanne, got a minute or two for you.
Sorry, I'll be quick. I think it's some brilliant work. I've just got a question about the medication safety debriefs. Obviously, I think I heard that you said that you try to do those within the first 24 hours of an incident. So how do you get that information from the people? I assume that won't be necessarily involving the people who were involved in the incident because they may not be on shift. So how do you then get that information from the people who were present to make sure that the learning's accurate, and also if there's other areas that have been involved in the incident as well? So just wondered if you could explain that. Thanks.
Yeah, I think Charlotte's going to take that.
Yeah, so this is something we spoke about at significant length, really. And something, as we go on, I think the process will evolve alongside our findings. So at present, what we discussed was like a sort of nursing charge to nursing charge handover of the incident if it was sort of out of hours. But actually, so in that instance, there should a lot of the information should be handed over, and there's not too many people involved in the process. And again, that's something that we might come across issues as we put this into practice regularly within our areas. The other thing we spoke about was actually if the DATEX is reported in hours, which is what we tried to sort of do yesterday and put into practice. Could you try get a pharmacist and a medic and a nurse together to try and see if we could action it sort of there and then, which we were able to do yesterday. We've had different feedbacks in regards to, if the person involved in the incident would want to be involved, and I think some people would and some people wouldn't. Some people will find that beneficial and some people wouldn't. And I think that's something you just have to gauge, having that open and honest sort of culture and a non-blame culture going forwards.
And we'll keep testing and be able to feed back at the next report out.
Yeah.
You will still speak to the person involved.
Yeah.
That bit of the process won't go, will it? Like you still have that health and wellbeing checking with that person.
Yeah, and I think the idea is not necessarily about that individual. It's about trying to review the whole process and everything involved in that. More of a different way to look at it, essentially.
And Kate's made a great point there that it's a rapid process improvement workshop a week, isn't it? The learning will continue with the 30, 60, 90 days, and hopefully after that 90 days we'll have some really solid learning that we can scale up and share with everybody else so that everybody can adopt that good practice. I'm really conscious that we've run over, but I just wanted to point out that there's so many key themes from both of those around sharing learning and system learning and bringing people along with the journey. So lots of learning from each of them. I'm really excited to hear about the 30, 60, 90, and we'll make sure that we all tune in for that. But for now, 3 minutes over, I'll draw us to a close. Thank you so much. They were both fantastic. Right. See you soon. Bye-bye.